Welcome back to the ACRO Podcast. I'm Dr. Nevine Hanna, and this episode of ACRO Podcast is being brought to you in partnership with Myriad Oncology. Our guest today is Dr. Christopher Lee, and we'll be discussing genomic testing and the intermediate risk prostate cancer. Dr. Lee, we're so glad to have you. Can you please tell us a little bit about yourself and your practice?
Yes, hi, I'm Dr. Lee. I'm a practicing radiation oncologist in Spokane, Washington, and I've been in practice here for 19 years. And I, over those years, have had the opportunity to work with many wonderful partners and others here in our community to work to provide care for patients with a number of, all types of different malignancies. But as we're focusing on today, specifically been able to be a part of the care for many patients with prostate cancer. I'm also involved with teaching medical students here. There are medical students that we work with here and mentor with research projects, as well as for clinical shadowing from University of Washington and Washington State University. And so we're lucky also to be able to have an influx of wonderful young minds who are interested in learning and expanding their knowledge, and also helping and participating in ongoing research.
Wonderful. That sounds very exciting and a well-rounded aspect of both clinical practice as well as the research aspect of our field, which is extensive, as you well know. And would love to hear from you if you can describe the current landscape of intermediate risk prostate cancer, particularly the distinctions between favorable and unfavorable categories.
Yeah, so as it is with many different types of malignancies, as research continues, then as we evaluate and talk to patients, then we utilize a variety of tests to put patients into different categories of decision making, really, of how to best treat that cancer. And when it comes to prostate cancer, there's a wide spectrum. There are some patients who are diagnosed with very indolent or slow-growing, non-aggressive prostate cancer, all the way up to those who have very aggressive, fast-moving, fast-spreading, and an immediate risk to their life type of a situation. And so, in the intermediate, kind of in the middle of those patients who have localized prostate cancer, is a group of patients who have cancer that can have also a spectrum of different biology. Some of those cancers in the intermediate risk prostate cancer group need treatment, and some need more aggressive treat than others. And there are also a group of patients in that intermediate risk localized prostate cancer group that can be observed and be watched and followed with a active surveillance type of a paradigm. And so this is a group of patients where, when we see them, in the back of our minds as clinicians, we're always looking at all of those aspects and trying to decide, for the patient sitting right in front of me, how can I individualize the treatment for this gentleman? What are his comorbidities? What are his life circumstances? What is his Gleason score, for example, his PSA? What did the pictures, the imaging show? And all of those various features we put together, as well as added to genetic testing and genomic biomarkers, to help us to further categorize and make an individualized decision for those patients.
So are you telling us that for the new medical students and the new residents and the new docs that come, the unfavorable or favorable prostate cancer, it's not just about a 4+3 or 3+4 in the intermediate risk. It goes a lot further than that. Is that what I'm hearing?
Yeah, I would agree with you on that. I completely agree. And in the future, we're going to learn even more as we further subdivide and further subcategorize these patients. But we do know that there is a spectrum of aggressiveness to prostate cancer within the intermediate risk category. And some of those patients need more aggressive treatment. So, For example, I'm a radiation oncologist, and I work with urologists, wonderful surgeons, and who do robotic prostatectomies. But as a radiation oncologist, when I see these patients, and in my mind, if they're a candidate for radiation therapy, I'm thinking about what are the different types of radiation that this patient should be offered. What are the different techniques that will provide the best benefit? Should one critical decision that's always in the back of my mind and that patients are coming with questions about our hormone therapy, ADT, is that going to be beneficial? And so these are all the things that, again, as we further stratify and risk stratify and help to um, talk about options with patients, we can utilize these genomic biomarkers and genetic testing to help us to give our patients more information.
Great. Now, in terms of the specific research and your thoughts on this research, when you started doing this, what specific unanswered questions or clinical uncertainties were you hoping to address?
Yeah, so when you look at breast cancer, for example, genetic testing has been part of the diagnosis and workup for patients with breast cancer for many years. And prostate cancer um, is behind the curve when you look at breast cancer as a comparison. But over the last decade, there have been significant advancements looking at genetic testing and genomic biomarkers when it comes to prostate cancer. And my hope or my interest with this research was to get some real world data, look at what's out there to tap into a large database of what has been done, and to look at, how frequently is this being done? What are the results showing specifically for patients with intermediate risk disease? What are the genomic biomarker results? And by using that real world registry, I think that informs us, helps us to understand better as clinicians patterns of care or patterns of analysis, and helps us in the future move forward with additional studies and additional questions, actually, of how to better take care of each individual patient.
So what does, as NCCN, as what every doctor goes to determine what to do with the patient, which may be a little generic at this point, and we need this additional information to help the patients. But what does the current evidence tell us about genomic testing, refining risk assessment within the NCCN intermediate risk categories?
Yeah, so as you mentioned, we utilize the NCCN guidelines as clinicians every day. It's part of what we do in our tumor board discussions and our discussions with colleagues. And the value of that NCCN guideline goes on beyond just that printed copy, but we know that it's always being analyzed and looked at and updated. And so, there's always new things being done. When you look at genetic testing, again, it's evolving. If you look at the last few iterations of the NCCN guideline panel recommendations, it's been evolving. And there are a number of tests out there. There are, a variety of genomic biomarker tests, as well as tests looking at familial genetics, and it's certainly something that's recommended to be looked into. And for these patients who are intermediate risk category patients, again, we're continuing to evolve in how to utilize these tests to inform us in making those critical decisions. I think the big question is, with multiple options, how do you choose which option? How do you know which option is best for that patient that's sitting across from you? And I think just like anything else, it needs to be an individualized decision making of what is the question that I need answered for this patient who sits in front of me. And so, for example, when as a radiation oncologist, I'm trying to make decisions about whether or not to add ADT for a patient who's getting radiation treatment, then I look at those tests and I try to help, to determine as a clinician, and when I give this result to a patient, how are they going to be best helped to make their decision?
Yeah. I do have this question coming to me in clinic every day with my prostate cancer patients. I hear about the side effects of ADT. Can I avoid it? Is it going to be beneficial to me? Now, you see, there's a lot of information out there, and like you said, there's a lot of genomic profiling and data. And what makes one test, different from another, or do all the tests out there address specific questions? There's Polaris, there's Decipher, there's Artera, there's all kinds of stuff out there. What is the difference and what's the distinction, and where do we go to in terms of ordering these exams or tests when we want to find specific answers, or do they address different questions?
Yeah, so I think they, of course, each um, of the tests has a backbone, a background of research that's been done in different populations of patients with prostate cancer. And so part of the question when I'm sitting in front of a patient is, which one of these tests is going to help me to answer the question? So as an example, if I have a patient who has an intermediate risk prostate cancer that's localized and I'm planning on utilizing external beam radiation treatment with IMRT. I'm planning on using a moderately hypofractionated plan, for example, and talking to the patient about whether or not to add ADT. The Prolaris test, for example, gives me statistics on what are the outcomes if I use radiation alone, what are the outcomes if I use radiation plus ADT, and it also calculates the absolute risk reduction of adding ADT, how much that reduces the risk of distant metastatic disease. And so for that question, I find that to be extremely helpful. Some of the other tests are beneficial in the post-prostatectomy setting. For example, if I'm seeing a patient post-prostatectomy and they are having a biochemical relapse, then I look at other tests. And I think when you're looking at ADT intensity, there are other, a variety of tests that can be either used in combination. I think sometimes we're using now two of these tests to help us make decisions rather than just picking one, but we use a combination. And so it in some ways has become more complex because the science is still evolving. We haven't arrived at the final genetic test that will answer all questions, but we do have more tools today in our toolbox when we're sitting down in front of patients to help them along their cancer journey and to make decisions so that when we make a clinical decision and we move forward, those patients have peace of mind that
True.
they feel informed in making that decision.
Absolutely. Very true indeed. I am curious whether you found some very surprising or specifically meaningful data that emerged from your analysis. Was there something that in particular you went, huh, light bulb?
Yeah, so I guess just to highlight, we looked at within this large database, 118,000, over 118,000 patients who had prostate cancer and had genetic testing done. Um, the There were over 60,000 who fell into the intermediate risk prostate cancer category. And then again, we further subdivided into favorable intermediate and unfavorable intermediate risk. Interestingly, we found that that when you look at recommendations for active surveillance versus doing single modal treatment, which is defined as a recommendation for surgery or for just radiation treatment alone, versus a more intensified treatment, which for me as a radiation oncologist is adding ADT to radiation therapy. We found that individuals with favorable intermediate risk prostate cancer were more likely to be recommended active surveillance within this database, whereas those with unfavorable risk prostate cancer were more likely to be recommended to single modal treatment. And when you look at that as a whole, It provides some really an interesting window into this intermediate risk disease, but you can see also within that unfavorable intermediate risk category, there were smaller percentage of patients who were also recommended, who had less aggressive biology, who could be considered for active surveillance. And there were also patients who fell into the multimodal threshold where ADT was recommended because of their biology. We know that the prostate cancer cells, they haven't read the textbooks. And so, the cells themselves, they don't know that they're supposed to behave a certain way if they fall into that category based on their Gleason score and their PSA. They all have an individualized genetic code, and that gives them a different biology and a different aggressiveness.
Yeah. Now, when you see this patient with a 3+4 intermediate risk, and you tell them, hey, the test results from Genomic said that you can potentially be surveilled instead of undergoing any treatment. Do you have any takers on that? And have you
Yeah,
found the
it's
change?
a good question. And as you're aware, it's very individualized. You might have somebody who is in their, 80s, for example, or who is very frail and who has a significant heart disease, lung disease, kidney problems, other significant comorbidities. And them hearing that, it might give them some peace of mind to say, hey, I've got other more important things I'm dealing with on the top shelf, and let's put this kind of down on the lower shelf and we'll just watch it and kind of monitor things. Whereas if you have somebody who's younger and who's very active and very healthy, and even though they fall into that category, that's a more difficult discussion, because we know that those patients who fall into active surveillance category, that doesn't mean that they'll never have treatment. That doesn't mean that they're not going to have eventually treatment. That just means that they're going to be, the key word is active. They're going to be actively surveilled with follow-up, with further PSAs and repeat biopsies and further imaging down the road. And someone who's young and active, who we know is high likelihood of needing treatment down the road, then often that's, not what they want to do, and not the end decision. But I think, again, the data becomes helpful because you're able to provide your patient with more information about the biology of their cancer, so that they have this additional information to make an informed decision and to feel comfortable and calm about the decision that we ultimately embark in.
Very well said. Now, I'm going to ask you the tough question, and I get this all the time from my patients.
Yeah.
How do you convince your patient that really can benefit from ADT and they have their mindset, they've done their research, they're brilliant, they're well studied, high level of education. I don't want ADT. And
Yeah,
the test says clearly you can benefit.
yeah, great question. So, of course, the patient in the end always has the say so. They get to make the final decision, and there's no force or pressure, or it's always the patient's choice. And our goal is to give them as much information as possible, to help them to feel, again, comfortable in their end decision that they make. um, I think when you have statistics, it's not just Dr. Lee thinks you should do this, or, the NCCN guideline says you fall into a category, therefore it's most likely that you're going to benefit from this. I think it can additionally help them to have individualized statistics that's coming from, an outside source, not just Dr. Lee, and his team, but it's an outside source that's also providing some statistics on with or without hormonal therapy, and the absolute benefit of adding the hormonal therapy to the radiation. Again, as a radiation oncologist, I'm focused on that absolute benefit. And that helps them to, in the end, have additional information to make a decision that they're comfortable with.
Yeah, that's truly all we can do is provide the data, and then they ultimately make the decision, knowing everything. And I feel like a lot of the patients do get empowered by having this data and statistics, and knowing this large number of patients that were in this study, from which you concluded some wonderful results.
Oh,
Now,
thank you.
yeah. Now, what are some unanswered questions and that your research may have raised that you may be looking into the future or working with?
Yeah, so I think, as a radiation oncologist, we're continuing to look into the future and hopeful that additional research down the road will help us to further make decisions. For example, the questions that are on our minds is, what type, there are various modalities of radiation and different doses of radiation that we can use over different, various numbers of days. Should the treatment be a short course or should it be a longer course? Should the doses be bigger each day or smaller each day? Is brachytherapy as a boost, for example, or as a single modality beneficial? And how do you choose which patients are most likely to benefit from that? We're also, on each individual patient trying to decide how do you decide whether to add the lymph nodes in the pelvis to the plan, or do you just treat the prostate alone? All and then with the ADT question, how long should the ADT be that's optimal for that patient who's sitting right in front of you in the exam room chair? And so these are all questions that we face every day, and we have a lot of information to help us make decisions at this point. But the more information, the better. And I suspect in the future, with additional studies and research and with additional power with statistical methods and big data, AI, it'll be interesting in the future how the science continues to evolve to help us to answer these questions.
Yeah, AI and genomics are very exciting. I feel and I envision this going way beyond what we've ever imagined. Maybe having, instead of a couple of algorithms, having hundreds of algorithms in the future. Now, I would love to hear from you. You're an expert in this field. What would you like your audience to know? Or is there anything that I haven't addressed that you'd like your audience to know about genomic testing in the field of prostate cancer?
Well, I would say I believe genetic testing is very important for patients who are diagnosed with prostate cancer. I think it's very important to, in the future, as we talk to and meet with and take care of patients with prostate cancer, that we provide them with all of the tools that are available. I think it's important as a take-home message that we continue to strive for additional studies, additional research in the future, that we support that we, any way we can, try to participate and aid in bettering the science so that in the future, patients that we take care of will even have better information, will even have better evolved treatments that are stratified and or that are customized for their individual situation. I enjoyed, again, working with students and being a part of studies, and that's the future. That's how we get smarter. That's how that will allow us 10 years from now to be doing an even better job of taking care of our patients and to help them get through treatments that are going to optimize their quality of life and optimize their ability to enjoy life and do the things that they love.
Absolutely. Very true. Thank you, Dr. Lee. This was very enlightening and very helpful to all of us. Thank you for being part of our ACRO podcast, and we hope to see you very soon in the future. And here's a goodbye, and we'll see you in the next ACRO podcast episode.
Great. Thank you for your time. Appreciate your interest in our study.